It Takes Balls is brought to you by our new sponsor, D's Nuts. Yes, you heard that right. If you've never heard of them, check them out at grabdsnuts.com. But warning, these are not your grandparents' peanuts. D's Nuts is really shaking up the nut game. They're gourmet, fun, and packed with flavor. Whether you're a fan of savory flavors like ranch, sriracha, or hot cheddar, spicy like ghost pepper, or if you have a sweet tooth like me, you'll like the banana pudding. D's Nuts has something for everyone. But D's Nuts aren't just about taste, they're about making a difference. For every bag, can, or piece of D's Nuts merch purchased using the coupon code NUTCHECK on grabdsnuts.com, you can save 10%, and another 10% gets donated towards supporting Testicular Cancer Awareness Foundation. So the next time you're craving a snack that's both delicious and meaningful, reach for D's Nuts. Because when it comes to supporting Testicular Cancer Awareness Foundation, it takes balls and it takes D's Nuts. Available at grabdsnuts.com, Amazon, and Walmart locations nationwide. D's Nuts, a delicious, healthy snack in a variety of fun flavors and making a difference one nut at a time. The stories shared on It Takes Balls are unique to the individual sharing. Always speak with your trusted medical provider for treatment options specific to you. Welcome back to It Takes Balls, presented by Testicular Cancer Awareness Foundation. Today I'm joined by the Chief of Urology at the Greater Los Angeles VA Health System and Assistant Professor of Urology at David Geffen School of Medicine at UCLA and Testicular Cancer Awareness Foundation board member, Dr. Joseph Shirk. Dr. Shirk, thank you so much for being here.
It's great to be here. Thank you. Thank you for having me on today.
So this episode, we've done a lot of episodes with doctors talking about like very specific things, but this one, I feel like we needed to have an episode where we talked about like the stages and the different terminology. So if you wouldn't mind, let's get into like what the different stages are for testicular cancer. Like I know there's 0, 1, 1A, B, et cetera. So let's start with 0 and go from there.
Yeah. So like you mentioned, 3 different stages, 4 if you count stage 0. And if you want to start with stage 0, which seems like the logical starting point, that's a very simple type of stage to talk about. So the cancer in that stage is actually just in the seminiferous tubules. So those are the small tubules that are inside of the testicle. It hasn't grown into any of the other parts of the testicle. And then importantly, it also hasn't spread to any nodes. It hasn't gone to any other areas of the body. So you may see, when you look at staging, you may see a T, an N, an M, and an S. And so just to explain right up front what those are, the N stands for nodes. So those are lymph nodes that the cancer may have traveled to. The M is metastasis. But think about that as other distant parts of the body that aren't lymph nodes. So things like the lung or the liver or the brain, things like that are not specifically related to lymph nodes. And then the S, those are tumor markers, which we'll talk about later on, but those are lab tests that we use for folks with testicular cancer to kind of define the staging and to measure the level of that cancer within the body. So again, for stage 0, this is kind of if you're thinking about building a house here, this is the basement. It's just within the tubules, within the testicle. It hasn't grown into anything else. It's not in any lymph nodes. And it's not in any other part of the body. And those tumor markers, those lab tests are completely normal.
How does stage 0 kind of present? Does it present as a lump the same way any of the stages would, or is it just incidentally found?
Yeah, it can be either. So sometimes people get ultrasounds of the testicle for reasons other than feeling a lump there. Sometimes there's pain, sometimes there's swelling, sometimes there are other things that are going on there. Occasionally this will present as a lump too, but it can present as either one.
Gotcha. All right, now let's talk stage 1. There's 1A, 1B, and 1S.
Yeah. So again, this is kind of the first floor of the house. Now, as we move up, this is a more common type of stage of testicular cancer that we see in folks. But let's break this into the 3 different categories. So it's a little bit more advanced than stage 0. So it's grown beyond those seminiferous tubules. So it's outside of those small tubules within the testicle, but it's still within the testicle itself. So it hasn't grown outside of the actual testicle. It hasn't grown into any of the other lymph nodes or the blood vessels or anything like that. And it hasn't spread to any other parts of the body. So think about this as T0. But now the tumor's just gone beyond the seminiferous tubules, the small tubules within the testicle. So that's 1A. 1B is just kind of the next step beyond that. So now it's grown outside of the seminiferous tubules. It's grown outside of the testicle itself, but it still hasn't grown into any blood vessels, any lymph nodes, or anything like that. So it's still just within that the scrotum, hasn't grown anywhere else, and those tumor markers are still normal. And then for 1S, so this is a little bit different. So it's grown outside of the testicle, but in some cases it actually hasn't. So it's either within or without the testicle. It hasn't spread to any other parts of the body. But in this case, actually, the tumor markers are abnormal. So those blood tests that I mentioned before, one of the three that we normally use is higher than normal. So that's 1A, that's 1B, and 1S. So again, it's just kind of one level up from that stage 0.
Gotcha. And then stage 2, we got 2A, 2B, which was what I was, and then 2C.
Yeah. So again, these are becoming a little bit more common now. So as you mentioned, that was the stage at which you presented. And normally we see folks that present with a mass, and then there are some tumor marker abnormalities as well. So now we're kind of getting into the area where most folks will sit. So for 2, again, there's an A, a B, and a C. So instead of an S, now there's a C at the end here. And the reason for that will become obvious in just a minute here. So for 2A, the tumor may or may not be within the testicle. So again, it's kind of like that 1S that we just mentioned. It spread to one of the other lymph nodes within the body. So at least one of the lymph nodes. So at least one, but less than 5. So it's kind of in that 1 to 5 range. None of the lymph nodes are larger than 2 centimeters. So there's a size criteria here. It's not spread to any other parts of the body. So it is not metastasized to the liver or the lungs or the brain or anything like that. And the tumor markers can either be normal or one can be a little bit high. So staging for testis cancer is a little bit complicated. As you can see, as I'm talking through these, there's a lot of information that goes into this, but just think about this as one step higher than that stage 1. Now your tumor markers are high and there's some lymph nodes involved. So that's usually how I like to think about the 1As. The 2As. The 2Bs are similar. Again, it may or may not be in or outside of the testicle. Now the lymph nodes are a little bit larger. So instead of being 2 centimeters or smaller, now they're larger than 2 centimeters, but they're anywhere from 2 to 5 centimeters. So they're still in kind of that intermediate range. It hasn't gone to any other parts of the body, so no metastasis. And then at least one tumor marker may be abnormal. So the difference here between that 2A and the 2B is really the size of those lymph nodes. For 2C, we're just kind of going up in lymph node size again. So again, everything is very similar between 2B and 2C, except for the size of that lymph node, which is now greater than 5 centimeters. So now you're dealing with some relatively bulky nodes. Okay, so that's stage 2. Again, it all has to do with the sizes of those lymph nodes.
And then for stage 3, we've got 3A, 3B, and C, just like 2. So what is it, like a size component with those two, or?
Yeah, so it's a little bit different for the stage 3. So now we're talking about more the metastasis, so going to other areas of the body. So stage 3A, the tumor may or may not be inside the testicle or protruding out from the testicle itself. It may or may not have spread to other lymph nodes, but it has metastasized to some other area of the body. So some other area has some tumor there that you're able to see on imaging. And again, with the tumor markers, they may be normal or one or more may be elevated. So again, this is more about that metastasis than it is about the lymph nodes now. The same thing with 3B. So 3B, the tumor has metastasized somewhere else. Now there's 2 different variations, which is where it gets a little bit confusing here. There's also 2 different variations for stage 3A, and this is where it gets confusing, and I want to make sure everyone is clear on it. So for 3A, it's an either or. So it either has metastasized to some area of the body, or it's spread to multiple different areas of the lymph nodes. So it's an either or for both of those. And if we work up from stage 3A, the tumor marker levels also go up. So for all of these stage threes, now the tumor markers are much higher than, so they're elevated well beyond what they should be in a person without testis cancer. So thinking about this, think about A, B, and C just being wider spread disease, more metastasis to other parts of the body, and more involvement with lymph nodes, although there's not necessarily a requirement to have spread to a lymph node as long as there's metastasis somewhere else. That can classify you as a 3A, B, or C.
Gotcha. Okay. And then notably for testicular cancer, there isn't a stage 4 like most other cancers. What's the reason for that?
Yeah, the reason is that the complexity within each of the levels for these testis cancers is very high. So as you saw, as we were just discussing here, I mean, it took me quite a while to explain the differences in each of these different levels. And other tumors, other cancers tend to be a lot cleaner and a lot easier to define those different levels, and they split them up rather than having an A, a B, and a C. It's more defined as just, here's stage 1, here's stage 2, 3, and 4. So there's no stage 4 because you've already gotten all the way to the maximum amount of disease by the time you've gotten to stage 3.
Gotcha. Okay. And next I want to talk about the cell types, but kind of a question that will hopefully segue us. With these different stages, I mean, we talk about testicular cancer being 95% curable. Unfortunately, there are the 5%. But with each stage and maybe depending on the cell type, is there a different, is there a better or worse prognosis? Or is it just based on metastasis and 3C is just as treatable depending on the cell type as 2A?
Yeah, it's a really good question. So we like to think about testis cancer as everything being treatable. So if you take the most famous testicular cancer survivor, Lance Armstrong, I mean, he had one of the highest stages of disease. He had a very aggressive tumor. He had metastasis in the brain, but yet he still, with the appropriate treatment and chemotherapy and everything like that, he was able to make a full recovery. So everyone always asks, and I would ask the same question, what your individual prognosis is and give me some numbers. The bottom line is all that matters is the numbers for you as an individual. And, those numbers are usually more difficult to give. So if you think about it in general terms, yes, the more aggressive tumors and the higher your metastatic burden or your burden in your lymph nodes, the more difficult that will be to treat. But again, I think the way we want to think about this across the board is it's very treatable as long as you're getting in there and you're following a treatment and a surveillance plan.
Gotcha. All right. So now let's talk cell types. We know there's seminoma and non-seminoma are kind of the common ones. I also found information on stromal, which was news to me. So let's start with seminoma.
Yeah. So the way that you want to break this up into categories is seminomas, non-seminomas, and then there's a whole bunch of other sort of a little bit more unusual tumors that we don't see quite as often. We can talk about those a little bit, but those are more rare tumors that are treated a little bit differently than the classical testis cancer tumors. So for seminomas, that's the first category. They tend to be a little bit less aggressive and slower growing tumors. So they come from those seminiferous tubules. There's two different types. There's a classical seminoma. About 95% of seminomas are the classical type. So that's the one that you're going to see the most of. They fall into that general age group. Usually men in their mid 20s to mid 40s can end up with a seminoma, although you do see them in younger to older men for sure. A spermatocytic seminoma is sort of the variant type that you see that is different than a classical seminoma. That one usually happens in older men. They're relatively slow growing tumors, and they're usually localized to the testicle. But again, it's only about 5% of men, and they tend to be a little bit older. And then these tumors, they all produce a little bit different sort of a potpourri of the tumor markers. And the seminomas are notable for producing HCG. So you'll see that in seminomas. They don't produce some of the other tumor markers that we see, but that HCG is kind of a classic tumor marker for seminoma.
Gotcha. All right. And then non-seminoma, what's up with those?
Yeah, so non-seminoma, we call those germ cell tumors. So those tumors come from a different type of cell within the testicle, and there are a couple of different subtypes within those. And those subtypes are embryonal carcinoma. You see yolk sac carcinoma as well, choriocarcinoma, and then there's a fourth one, which is a little bit different than the other ones, called a teratoma. So I'll walk you through those. Most germ cell tumors, when you see a germ cell tumor come back on pathology after an orchiectomy, usually it's not just one of those. So usually it's a mixed tumor of a couple of different types there. Interestingly enough, even though it's a mixed tumor, you would think, well, maybe my treatment will be different because it's a mixed tumor. It's actually not. So the treatment that you get, no matter what, for a germ cell tumor, is going to be the same, even if it's a mixed tumor. So to start from the top, so embryonal carcinoma, just comes from a certain part of the testicle. It produces two of those tumor markers, and it usually produces them at pretty high levels, most notably AFP, or alpha fetoprotein. So it produces that tumor marker. It also produces some HCG, just like the seminomas that we just discussed. Another one that we see commonly is yolk sac carcinoma. The reason they call it yolk sac, it kind of sounds almost like an egg, but that's not the actual reason. It looks almost like the cells that you see in an early human embryo. So remember, these are cells that have kind of gone wild for some reason, and oftentimes they do look like cells that they shouldn't. So these tend to look like cells that are that look more like an embryo cell. Sometimes you'll hear some older terminology around these tumors, but really yolk sac tumor, is kind of the preferred terminology at this point. You can actually see these tumors in much younger folks too. So you'll see them even in infants. And those are usually pure yolk sac tumors. So again, this is not the age population really that we're discussing here, but if you're going to see a mass in a very young child, that's usually what it is. Again, very responsive to chemotherapy, very high levels of AFP. So alpha fetoprotein is a tumor marker that we'll see for these as well. And then for the last two, so choriocarcinoma, this is a little bit more rare. It tends to grow a little bit faster. It tends to spread a little bit more. So it tends to go to other parts of the body, can go to the lungs, it can go to the brain. Those are kind of the top two where we usually see this spread. Occasionally you'll see it in the bone as well. Again, this is usually mixed in with other types of tumors, so with a yolk sac tumor, or with other germ cell tumors. When they're mixed, we usually, consider that a better prognostic factor. So your treatment, we usually are a little bit more confident in. But when you see choriocarcinoma mixed in there, it does, make you a little bit more concerned that this is a little bit more aggressive of a tumor. And this one produces a lot of HCG. So again, they all produce something a little bit different, but this one produces HCG. And then the last one, so this is kind of the oddball of the group. It's something called a teratoma. It's a germ cell tumor, but it looks like a bunch of different things. So this is probably deeper than you want to know, but in the embryo, there are different layers. There's the endoderm, the mesoderm, and the ectoderm. It looks like tissues that are derived from each of those. So if you look at it under the microscope, it may look like teeth, for instance, or it may look like cartilage. It looks like very, 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 very odd things, especially under the microscope. They're pretty rare. So to have a pure teratoma, it's pretty rare. In the testicle, they don't increase AFP or HCG. So normally those are marker negative tumors, and they're usually part of a mixed tumor. The important thing though with teratomas is we tend to see them later on. So sometimes after chemotherapy, if you still have masses in your lymph nodes. So usually those are in the retroperitoneum, which is kind of the area of the body next to your aorta and the vena cava, which are the big vessels that run up and down in the body. We see them kind of, those lymph nodes, if they're still going to be there, we see them around those vessels. Sometimes you'll see those continue to be teratoma, even after all the rest of the tumor is treated. And that's because the chemotherapy does a very good job of shrinking down all of those other cells and treating those. But sometimes what's left over is teratoma. That teratoma sometimes over time can transform. So it can transform into other types of cancerous cells. And that's really what you want to stay away from as much as possible. That's why a lot of folks end up getting surgery if there's residual masses there. So something like an RPL&D to take care of those tumors. So that's really the rundown of the major types of testis cancers. That's seminoma, non-seminoma, those germ cell tumors, and then everything else. There are some other tumors. There are things like you mentioned called stromal tumors. There are Leydig cell tumors. There are Sertoli-only tumors. Those are all tumors that arise from different parts of the testicle that are much more rare, and they can be treated in a little bit different ways. But for the purpose of what we're talking about today, I think these kind of fall outside of that general category of your normal testis tumor.
Yeah, that's great. You mentioned the tumor markers, so let's briefly talk about those. We've got AFP, HCG, and LDH. I don't know if LDH is that used anymore, or is that?
It is, yeah. It's lactate dehydrogenase, so it can be produced by a lot of different things. So it's a very non-specific tumor marker, but it is still one of the big three. So you mentioned all three of them right up front there. Those are the things that we look for as our traditional tumor markers. There are some other, I would consider them more historical type tumor markers that people have used in the past. So there's something called placental alkaline phosphatase. That's a very, very general tumor marker. We don't generally use that anymore. So when you're talking to your physician, it's really those big three that you want to think about.
All right.
And then the key with those, if I can just go a little bit further on those. So the key is you want to see where you start out with those tumor markers. So normally, as we went through the stages before, you saw that most of those stages have an elevated tumor marker somewhere in there. So you want to see those tumor markers before, and it's very important that you measure that before you have any sort of procedure or surgery. So before you have an orchiectomy, make sure that's measured. And the reason is that sets the baseline for everything else from there on out. So it sets the baseline to see how fast are those tumor markers dropping, and are those going to drop below what we would consider those normal and undetectable levels, which is really where you want to be. And we use that to guide a lot of the treatment as we go on with both chemotherapy and with potentially RPL&D and things like that.
So kind of to put a button on the three things we've talked about, the tumor markers, the cells, and the stages, when is the appropriate time to kind of be confident in your stage? Is it after your orchiectomy and you have the pathology? Is it after the CT scan? I know you mentioned like maybe metastasis to the brain. Like I never got an MRI up front. So how do you really know that you're not 3 if you're not getting those scans?
It's a fantastic question. It's a great question. So really you want to know a couple of things for your stage. And again, this all goes with those different categories that we talked about. Your pathology is going to tell you, it's going to tell you some stuff. It's really going to tell you more about the type of tumor you have than the stage. It may tell you definitively whether that tumor is in or outside of the testicle itself. But that really only comes into play for a few of these stages, the lower stages that we've talked about. Really, the important things are those tumor markers. And then, like you mentioned, a scan. And the sort of our standard of care scan is a CT. Some folks will get an MRI, but really a CT scan of the abdomen and the pelvis. And then we usually get a chest x-ray that goes along with it. So that will tell you a couple of things. That will tell you whether you have any metastasis in other areas of the body. So that's that M that we talked about with staging, but it will more importantly give you that N. So any lymph nodes are going to be very apparent on those CT scans. And we're looking in the retroperitoneum. We're looking in what's called the iliac chain, which is a little bit lower than that. If you have any metastasis anywhere, or you have lymph nodes in the retroperitoneum or anywhere that's picked up on that scan, there's this rule that we use called 1 level higher. So if you see metastasis in your retroperitoneum, you're going to want to get a CT scan of your chest to look to see if you have any masses in your chest. If you have masses in your chest, you're going to go 1 level higher, which in that case is the brain. So you're going to want to get a CT scan or an MRI to look at the brain to make sure that there's no masses there. Some folks will be a little bit more cautious, and if they see something in the retroperitoneum, they'll do both the chest and the head. The cases where you see metastasis go to the brain and kind of skip everything else are pretty rare, but you might consider that if someone has a more aggressive tumor like a choriocarcinoma or something like that. So it's a really good question. It's a long-winded way of answering it, but the only way to really know what your stage is by having all of those things. So after your scans, after your tumor markers, and then plus or minus after your actual after you actually get your pathology results.
So now let's get into like some of the words, and a lot of these were sourced from Reddit or my own, my chart or the testicular cancer support group. So the first two I have are benign and malignant.
Yeah, so this is an easy one. So benign is non-cancerous and malignant is cancerous. So, just a clear dividing line there. One are cells that don't tend to grow and multiply and spread in other areas of the body, and the other are abnormal cells that tend to do just those things. So benign masses of the testicle, they do exist. There are some, a few things that we see that are benign. However, if you have a mass that you can feel or that you can see on ultrasound and it's in the testicle, most of the time we'll end up doing an orchiectomy. We don't have a really good way of going in and getting a biopsy or other things like that to confirm that it's benign. Some folks will do what's called a partial orchiectomy, which is just taking out part of the testicle and leaving the rest behind. There's different data that says maybe that's a good idea, maybe it's not. I don't think we have a definitive answer on that yet, but benign testis masses are a little bit different in that most of those will come out anyways.
Gotcha. All right. The next one I have is adjuvant or adjuvant. How do you say that one?
No, you nailed it. It's adjuvant. So adjuvant is something that means after. Okay, so when we think about, and let's do this in the context of chemotherapy because that's how we're talking about it for testis cancer. For other cancers, we talk about neoadjuvant or adjuvant. So neoadjuvant is chemotherapy or other treatments that you get before you have surgery. So before you have that intervention, you'll get some other sort of treatment. A good example would be bladder cancer. So, a couple of days ago, I took out a bladder and, created a new bladder out of bowel. That's called a radical cystectomy and a neobladder for someone who had muscle invasive bladder cancer. So a serious form of bladder cancer. They get chemotherapy actually before they go to surgery. That's called neoadjuvant chemotherapy. It's been shown for bladder cancer, but that's very helpful. It kind of cleans up all of the tumor cells outside of the bladder and then allows you to perform a successful operation. For testis cancer, it's adjuvant chemotherapy. So it's chemotherapy that comes after your operation, so after your orchiectomy. There's a good reason for that. The reason is that the chemotherapy that we give for testis cancer doesn't actually get to the testicle itself. So there's a barrier there that doesn't allow that chemotherapy to cross and to actually treat those cells within the testicle. So you want to remove that testicle first. I actually did an orchiectomy right after this cystectomy that I did the other day. So someone had a very, very large, about the size of the grapefruit, testis mass that needed to come out. And the question was whether that mass should come out before or after the chemotherapy. Well, fortunately for this individual, he didn't have a lot of masses elsewhere in the body. So we decided to take the testicle out. But there are very, very, very few cases when you wouldn't get adjuvant chemotherapy. The only cases, in my opinion, would be cases where the tumor in the testicle has actually become smaller and there's a lot of tumor burden throughout the other parts of the body that needs immediate treatment. So then you kind of say, all right, we're going to put that testicle to the side and we're not going to think about that right now because there's so much else going on elsewhere in the body. So for the most part, for 99% of the time, it's going to be adjuvant, which means chemotherapy after an orchiectomy.
Gotcha. All right. I'm going to skip a little bit down my list here just because I think it's kind of related. Salvage chemo.
Yeah. So salvage chemotherapy would come after adjuvant chemotherapy. So if you've had, so let's go along the progression here. You've been diagnosed with testis cancer. You've had an orchiectomy. After that, the decision was made to do chemotherapy. So you've done that chemotherapy. And then for some reason, there's something that's still there. So either there are masses that popped up elsewhere in the body, or you had masses that shrunk to a certain level, but didn't quite get down to the level that you wanted to, or those tumor markers are still persistent. So they haven't normalized yet. There is something called salvage chemotherapy, which you just mentioned, which is, tweaking it a little bit, changing the type of chemotherapy that's given, and giving a couple more cycles to treat those masses. Sometimes what you'll see actually is a long interval between the two. So you'll see that orchiectomy, you'll see that adjuvant chemotherapy, and then you'll see that you do fine for a very, very long time, and then something pops up in the future. And in that case, it's still called salvage chemotherapy. It just happens much further down the road.
All right. And then, so, having too much platinum-based chemo, I guess, can lead to what I'll ask about next is platinum refractory.
Yeah. So, platinum refractory is an interesting concept. I would think about it more like refractory to treatment just in general. So what you'll get is an adaptation of cells to not respond to that specific treatment, whether it's platinum or whether it's anything else. And this happens for a whole host of different things. I mean, we have folks who have lung cancers that can be on a treatment that treat the lung cancer for years, and then all of a sudden that treatment doesn't start to work anymore. And the reason is those cells have adapted. They're now resistant to that type of treatment. So that's the same thing that we're talking about here. So for whatever reason, those particular cells are not responding to that particular treatment. And fortunately, we have lots of other treatments that we're able to do. Usually comes in the form of different types of chemotherapy. Sometimes will come in the form of surgery. So if you've got masses in the retroperitoneum that are still persistent, I'm a surgeon. I do a procedure called a retroperitoneal lymph node dissection, which is going in and actually removing all of those lymph nodes in the retroperitoneum, which is that area around the aorta and the vena cava that we talked about. I do that robotically, so it's through very, very small incisions. It's very minimally invasive. Some people will do it through an open incision, which is also just fine. But these are things that you can do when those tumors become refractory to other treatments, or when you've had good results from the treatment, but it just hasn't kind of finished the job.
Gotcha. All right. And then the other one, the next one I'll ask is remission versus no evidence of disease. Is there a difference, or is it just a change in terminology as we've evolved as a people?
Yeah, in my mind, it's the same. So no evidence of disease means you have no evidence from a couple of different perspectives. Your tumor markers are normal and your scans are normal. So there's no evidence that you have microscopic cells growing, producing a chemical that you can't see on CT scan. And there's no evidence with your CT scan that you have any nodes or metastasis anywhere. Remission, we think about as kind of making it so there's no cancer there for that particular point in time. So that's how I would define remission. People always will ask the question, what's the difference between remission and a cure? It depends on the type of cancer, but really the important part is that there's no cancer in your body when you're looking right then and there. So no evidence of disease and remission to me are very similar concepts.
All right. This next one might be something that somebody would see if they're looking at my chart before their doctor has reviewed it with them. LVI.
LVI. So LVI is lymphovascular invasion. That's something really that's more for the pathologist than anything else. Like you said, these get put into my chart and get sent out. And sometimes there's no explanation that goes along with it. It's a microscopic diagnosis. So with testis cancer, there are lymphatic vessels and blood vessels that kind of surround that testicle. And you'll see microscopically that the tumor goes into those lymph vessels and the blood vessels. That's how the tumors spread. So most of that testis cancer is spread through the lymphatic channels. So for those who don't know, the lymphatic channels are another system that's closely associated with the blood vessels, but basically it's part of your immune system. It takes up fluid and it's got a preponderance of immune cells that help treat diseases and things like that. I always tell patients it's almost like the garbage collector of the body. Anything that shouldn't be there gets washed into that lymphatic system, and it gets chewed up by your immune system. So in effect, what's happening when your testis cancer spreads to your lymph nodes is your body's doing its job. It is sucking up those cancer cells into that lymphatic system, and it's trying to treat them as best as it can in those lymph nodes. So lymphovascular invasion just means that tumor has hit those really small microscopic lymph channels, and that your body is most likely, taking those cells up and doing what it does to try to isolate that as much as possible.
All right. And then the next one is kind of, I think probably somebody saw it on their My Chart as a place that maybe something had spread, the tunica vaginalis.
Yeah. So in easy terms, think about your scrotum as a couple of different layers. You obviously have the skin on the outside. You have some deep connective tissue around that. And then think of the tunica vaginalis as almost a bag inside of a bag. So the scrotum is the bag itself. The tunica vaginalis is that tissue that immediately surrounds the testicle. As the testicle gets larger with tumor, it can invade into the tunica vaginalis. It really, from a patient perspective, it's just something that the pathologist is going to put on that report, but it doesn't make a lot of difference just overall.
All right. This next one probably is close to LVI, but I'll ask anyway. Spermatic cord invasion.
Yep. So these are all part of the same spectrum here. We're all talking about, as the tumor grows, what are the next things that it hits? The spermatic cord is composed of a couple of different things. So that is the cord that comes down from inside of your body that connects the lymphatic channels, the blood supply, and then also the vas deferens, which is that tube that, when you talk about getting a vasectomy, that's the tube that's snipped. That's the tube that actually carries the sperm from the testicles up inside of the body for ejaculation. So that's what composes the spermatic cord. As the testicle gets larger and as that tumor expands, it can invade up into the spermatic cord. So it can send some cells up there. Sometimes when you do orchiectomies, you will see that there's actually tumor that's climbed up that spermatic cord a little bit. And the key there is just getting above that and making sure that all of that comes out with the testicle.
All right.
One of the reasons...
Oh, sorry, go ahead.
I'll go back real quick. One of the reasons that we pull the testicle out, not through the scrotum, but through a little incision in the groin for these orchiectomies, is so that we're able to manage that whole spermatic cord and that we're able to take as much of that out as possible with the testicle.
Interesting. All right. The next one is clear margins.
Yeah, so that this is a perfect order for these questions, because I'm able to build on what you just asked me. So clear margins, we just talked about some of those tumors kind of marching up that spermatic cord and marching northward. Clear margins means not only did that area come out with normal tissue, okay, so normal tissue beyond the tissue that is cancerous, but also everywhere else around the outside of the testicle came out, and there were no tumor cells that they think were left behind grossly. So when I say grossly, I mean tumor cells that actually contact other parts of the scrotum or the area where the spermatic cord sits. So clear margins just means it looks like there was nothing left behind.
All right. What is the mediastinum?
Yeah, mediastinum is not usually involved in testis cancer. It's a pretty rare thing, but mediastinum is the area kind of between the lungs around the heart. And occasionally you'll see tumors that arise from the mediastinum that produce some of the tumor markers that we talked about today. So there are a few kind of oddball tumors that can arise there. And that may be the reason for the question, but it's usually not involved with testis cancer. It's not one of those primary sites where you see tumors kind of escaping and going.
All right. This one I think is related to the RPL&D, but I could be wrong. Full template.
Yeah, full template. So when we talk about templates, those are just standard means of dissecting lymph nodes. Okay, so I talked about a retroperitoneal lymph node dissection before. That is taking out all the lymph nodes towards the back of your abdomen. So you have a large blood vessel that goes up and down called the aorta. It splits into two other blood vessels called your iliac vessels that then go down your legs. The testis tumors, when they come up from the testicle into those lymphatic channels, they tend to concentrate around those iliac vessels and around the aorta and the vena cava, which is the vein equivalent of your aorta. A full template describes the patch of tissue that the surgeon is going to remove when they do your retroperitoneal lymph node dissection. Now, some people will do full templates, which involves a larger area. Some people will do modified templates, which involve a little bit smaller area. It all depends on the surgeon, what types of masses are there, what the tumor burden looks like, what some of the other priorities look like. For retroperitoneal lymph node dissections, there are nerves that sit right under that dissection that involve ejaculation. So, some newer techniques for performing these operations are very careful to spare those nerves. So a full template is just a descriptor of what that dissection would look like.
All right. You mentioned iliac. I don't know if there's anything else to add, but iliac chain is the next one.
Yeah. So within those templates, we define the areas that the nodes lie by the vessels that they're next to. So para-aortic are the vessels that lie next to the aorta. Intra-aortic caval are the vessels that lie in between the two. Paracaval are the vessels that lie on the other side next to the vena cava. The iliac chain are just those lymph nodes that lie around the iliac artery in the iliac vein.
All right. Left hilar.
So left hilar it's a anatomic marker again for lymph node dissection. So usually the top of your lymph node dissection goes up to the left hilar area of the kidney. So if you're doing a dissection on the left side, that's the upper limit of your dissection. The hilum of the kidney is actually where the vessels come from the aorta and the vena cava and go into the kidney. And so that's a good marker for us for our templates as sort of being the northmost part. We call it the most cranial part, which means towards your head, cranial part of that dissection.
All right. Hypoechoic mass.
Yeah, so hypoechoic is a term that's really specific to ultrasound. So the way that ultrasound works is it sends in these high frequency waves. Those waves bounce back off of tissue, and they bounce back differently off of different tissues. So hypoechoic is a description of what that mass looks like on ultrasound. If you see a hypoechoic mass, so if you look at an ultrasound report from a radiologist, they're going to give you a whole bunch of different descriptors, but usually there's going to be a summary that says suspicious for, testis cancer or something like that. These are all really specific terms that they use to describe how those waves bounce off of that specific tissue. So there's a whole bunch of things in there that kind of look and sound like this, but really the bottom line is how they read that scan at the end, putting all of that information together.
Okay. And then hydrocele.
So a hydrocele is not malignant, not dangerous. It is a totally different process. So it is fluid that actually gets trapped within that tunica vaginalis that we talked about earlier. And it's just fluid. It's not malignant fluid. It's not a mass. It's not within the testicle itself. But it may, when you do a self-exam, it may actually feel a bit like a mass, depending on how hard it is. Now, these things range anything from, the size of a plum to, we've seen these all the way up to the size of a small watermelon. They can get really, really large, but the treatment is completely different. The treatment is an incision in the scrotum and removing and suturing that area such that fluid can't come back. So fortunately, it's completely different from testis cancer. It's a completely benign condition. And the easiest way to tell the difference between the two, people actually used to take a flashlight and shine it behind the scrotum. And if the light shone through, that was a hydrocele rather than a mass because it's just fluid. The easier way now, get an ultrasound. The ultrasound will show you exactly what's going on.
All right. And then I'm going to add one. So there'll be two more. So I have microliths on my remaining. So what is a microlith?
Microlith. So this is a very common finding on ultrasound. So microlith is just microscopic calcifications within the testicle. It can be completely benign. Sometimes you will see it associated with tumors, but there are many, many scrotal ultrasounds that I've read that have had microliths and that are completely normal. So normally it's one of those other things that they'll put on a radiology report from an ultrasound that probably doesn't mean a whole lot for the patient.
Thank God. And then the last one, you have it on your paper. I don't even know how to say it, so I'll let you say it.
Yeah, it's reading testis invasion. So again, this is a microscopic finding that you're going to see on a pathology report. And again, as long as you know generally what your stage is and how you're proceeding with treatment, these are all really minor things that are more important for the pathologist than for anyone else. But it's invasion of a small structure within, kind of behind the testicle. Really shouldn't have any effect on the overall treatment or prognosis or anything like that.
Gotcha. All right. And then one thing I remember you said when we were in Chicago at the AUA, which has stuck with me, and I thought about it like once a day for some reason ever since, but you said that you learned that the sun should never set on a testicular cancer patient. So when I see people on like Reddit and the support group talking about, the urologist wants to have them come in for orchiectomy in 3 weeks, like, is that normal?
Right. So, I may have misrepresented that a little bit. We always used to say the sun never set on a testis cancer. So we would, a patient would come in with a testis tumor. We would try to get them into the operating room as quickly as possible because it is a relatively quick growing type of cancer, especially some of the subtypes that we talked about today. I don't think that's necessarily true anymore. I would say in my practice, what I like to do is get folks within a week. So if you come in with a testis tumor, we're going to try to get your labs, your scans, everything you need. If you need to do sperm banking and things like that, we'll try to get that all done up front for you within a week, and we'll try to have you in the operating room within a week. There is a bit of a process that involves getting into the OR. It's those things plus, meeting with another doctor to make sure you're fit for anesthesia and for surgery and talking with those folks. So, there's a little bit more involved these days, but I think generally if you kind of keep that 1 week time period, that time frame in mind, you can't go wrong with that.
Cool. All right. I think that's all I've got. A lot of these came from Denise, who you'll meet at the conference this September. So if you're listening to this before September 2024, we are having our conference, and we hope to see you there. Dr. Shirk, where can people find you if they want to get in touch or have any further questions?
Yeah, the best way to get in touch would probably be through the UCLA Health website. So you'll find me there on UCLA Health. If you Google the Department of Urology, that's probably the easiest way to find me. You'll see all my information there, and you can certainly send a message through that portal, and I'd be happy to answer any sort of questions that anyone may have.
Sweet. Dr. Shirk, thank you so much for being on It Takes Balls.
Of course, it's been a real pleasure. Thank you, Stephen.
For more information and resources for your testicular cancer journey, visit testicularcancerawarenessfoundation.org. You can also follow us on social media at Testis Cancer. We're on Facebook at Testicular Cancer Awareness Foundation.